shown this slide a couple times, but just to remember that this is already occurring. And what do I mean by that? We do have a lot of reports of either accidental ingestion, knowing animals that can get into pretty much anything. And as we, as a society, grow to have further access to psychedelics, it's a good chance that there'll be increased access for our pets as well. And then also intentional dosing. Okay, so we'll actually break this down into three main categories. It's accidental, as we just mentioned, intentional dosing. And so by this, I mean typically people who've had psychedelic experiences themselves, and then want to either share that or for some perceived for wellness or support, want to either microdose or give a larger dose of psychedelics to their animals. And then we have malicious as well, where there's no therapeutic kind of mindset or hope of providing support and just giving animals doses of psychedelics. And so these are different, and I think we will have to approach those differently as a profession. But today we'll focus more on accidental, and then I think the intentional is something we're going to be getting to down the line. But I think it's important for us to discuss these principles of harm reduction, and starting with how do we treat a patient that shows up that is accidentally ingested these substances. Malicious, it's going to be a little bit more nuanced, and something that might require law enforcement or social worker involvement. And so I won't go too much into that today, but I think it's definitely something we need to be aware of and discuss as a community as well. These principles, what does this mean for animal harm reduction? So some of the ones listed here: prevention of exposure, education and awareness, immediate care and response, supportive environment, veterinary training, something that we're starting to move into, bringing these concepts to our profession and how to safely recognize and treat and support animals in crisis. Harm reduction strategies overall, ethical considerations, legal, regulatory, post-exposure, research and evidence-based practices, and owner support and counseling. But today we're going to focus kind of on a couple of those, but mainly on education and awareness and immediate care and response in these cases. So the ASPCA actually has some great guidelines out there for just kind of poison ingestion in general. We'll be kind of discussing, why these aren't always would be considered a poison, but in some cases they would be. And maybe in the beginning phases, we do have to look at it or treat it this way. And so in last year, ASPCA released their top 10 toxins, and recreational drugs being number 10, but it's rising, it's growing. And so it seemed like it's joined the top 10 last year. And so we are getting increased exposure. So this does include cannabis or marijuana. This continues to rise, which we won't focus on too much, given the breadth of knowledge that a lot of this group and a lot of the services that Dr. Andre provide. We're going to focus more on what are the other psychedelic substances they may get involved in. And so, interesting to note, mushrooms, so both psilocybin and muscarine or amanita, muscaria mushrooms exposure are on the rise. So something that's important for us to be aware of. Okay. I do share this as well. I did share it in the reading from the Substack. I think this group has done a really good job overall. This is kind of a classing of psychedelic or hallucinogenic drugs with other recreational drugs, so including some opioids, cocaine, PCP, things that I wouldn't be considered psychedelic or therapeutic, as we're talking about them in maybe more in that slant. But it does have really good information. So I recommend both this one and a lot of the information that the ASPCA has put out as really, really good baseline information. And then we can, I think, discuss them or modify them maybe as we see fit. And yeah, before I'd like to read kind of a quote from From this specific paper, because I think it does discuss well, in a clinical setting, what should be the initial approach. So veterinary professionals will be held primarily accountable for the future growth towards a better diagnosis. It is critical to obtain an accurate history in order to gather information about the animal's environment, amount of exposure, time from exposure to onset of clinical signs, as well as type, severity, duration of clinical signs, all while assuring clients that the information shared is confidential and the focus is to provide the best possible care for their pets. Okay, so I think that brings up a couple important things, right? There's a lot that we don't know about these substances. There's a lot that we don't specifically know how to diagnose them. There's a lot of complicating factors when diagnosing, based off of legality or maybe the owner's apprehension to share accurate information. And so some of what I'm going to be presenting is based off of kind of an ideal situation where we know exactly what the animal has gotten. But we really do have to keep this in mind as veterinary professionals, unfortunately, that we might not always have a clear picture as we want. Okay, and so this, again, this ASPCA, they have a really good kind of summary of a lot of different illicit drug intoxications. So again, I do recommend having a read through that, and as we go into further discussion. So this is an interesting chart. It's from 2017. I think it will be updated soon. Something called the Global Drug Survey. So it does pretty good information. And again, this is very much human data. But it lists the comparison of people seeking medical treatment when taking a certain substance. And so whether this goes into direct safety of those individual substances, or just gives us an idea of how much maybe bad trips, negative experiences that people are occurring that would push them to seek out medical care. And interesting enough, so psilocybin or magic mushrooms being one of the lowest. Very few reports of people going to the emergency room for this. Cannabis a little bit higher, LSD above that. And then we get into kind of some of the more illicit, or I'm going to say harder drugs, cocaine, amphetamines, and then we have MDMA and ecstasy up there. And so these are the three that I'm going to focus more on today. All right, in some of the previous talks, we've gone deeper into the variety of psychedelics, or classical psychedelics and non-classical psychedelics. But I'd like to start with these ones because I think these are going to be the ones that are maybe most commonly seen outside of cannabis, presenting to us as practitioners. Okay. And so another thing to keep in mind, and of course, to what I understand, there is not this data in animals. I'm drawing a lot of this data from human trials or studies, or concerns of potential drug interactions. And so maybe your patient is on some of these already, and the biggest ones are going to be anything that alters serotonin, right? So our SSRIs, TCAs, MAOIs, and are going to be the biggest concern. Okay, and so I'm going to say this carefully because this is more what's coming out of the human literature and trial, that psilocybin, especially, not necessarily an interaction. There was often concern about potentiating that or causing serotonin syndrome. And again, it depends on the dose. But usually they find just people who are on antidepressants taper off of them before they go into a psilocybin ceremony, not always for the potential risk of serotonin syndrome, but more for a blunting effect, right? So people on SRIs are actually often using higher doses of psilocybin to get that same effect, or probably safer and better for everybody. And people are recommending weaning off of those SSRIs before entering into any psychedelic in general. But this isn't true for LSD or MDMA, as far as I'm concerned. Those potential could be very, very dangerous and easily cause a serotonin syndrome in our patients. Okay, Benzos as well, even though we might be using benzos to help offset anything that's going to alter mentation or neurological status, respiratory function could be in effect. So other drugs that we commonly use, so mirtazapine, trazodone, clonidine, any opioids, so tramadol, even fentanyl, morphine, anything could have a greater potentiated effect, and phenobarbital as well. And then in general, kind of a further caution, this is, I'm sure, going to be a growing list of things to be concerned or watch about, but if it's pediatric or geriatric patient, any cardiac dysfunction, especially when we're talking about MDMA, liver dysfunction, and then any seizure status, any epileptic or any abnormal neuro signs previous to this might just have different considerations or concerns for your patient. So going back, let's say we're not having an absolute crisis, or we're not suspecting serotonin syndrome. We're suspecting, let's give an example of the patient got into several grams of psilocybin mushrooms, appears normal, but we do see a psychedelic effect that is pretty profound. And so the patient's already, several hours into this. How do we treat it? And so what's a specific way to monitor a psychedelic patient in this framework? I think IV fluids, venous access would always be safest. Remembering to minimize stimulation overall, dim lighting, even calm music, and then keeping them nice and warm or thermoregulated. Vital monitoring, heart rate, respiratory rate, SpO2, blood pressure. I put this, but I also wonder, right? I wonder about the discussion, and really excited for input of being too hands-on versus hands-off, right? And I can only take this from kind of a human-centric point of view, being handled in that specific state, bright lights, things like this, poking, anything you're going to be, could just make things worse for that patient. So it's really going to come down to clinical judgment and what you think is appropriate. And of course, how much you trust the knowledge that you received, either from the owner. But I think it's something for us to discuss and consider. And so I actually consider or think about this in kind of a pre or post anesthesia care, and that it's not much different for me overall. Especially, let's talk more about the kind of post-operative care or anesthesia assessment. And I take this from, if you can see it, so this is from some RAVs, so a wonderful group, and I use this with their permission, of their beautiful chart that they've laid out of assessing anesthetic depth from stage 1 to stage 4. Stage 1, just kind of a quick recap, being kind of a pre-anesthesia phase, or we're not going to see too much changes, but and the patient's not out completely. But there might be some changes in vital signs, maybe their pupils change, things like this, and then going into a stage 2, that excitatory phase, or I'm going to say dysphoric type of phase, which we also may be able to see in the psychedelic phase, and then getting into kind of a anesthetized phase. I would think we're going to be more in stage 1, stage 2, maybe a light anesthesia phase, or might mimic kind of a light anesthesia phase if they're pretty out of it, but they should still be responsive to stimuli. Anything beyond that, yeah, that would get a little bit scary. I would think of more contamination, or if we're talking super high doses in some of these patients. So I think this is a good chart for us to refer to. And let's say we have our patient, we're monitoring it. Can we use these kind of charts to start to classify, to start to get an idea of what are the psychedelic effects and relate them to what we already know and are comfortable with? And so that's how I will sometimes approach these cases, depending on the situation. Okay. And then what about follow-up care in general? Let's say your patients have done well, you either decontaminated them or not, depending on the situation. They've recovered well, they're going home. we're all happy, but what about long-term or follow-up care? And so I think this is where it gets kind of more interesting. And this is what we'll go to in the next discussion group in a couple of weeks, because we think it's really important. We're knowing that these psychedelic experiences can reopen critical periods in these patients. And depending on the substance, depending on the amount, that could be weeks to months. And so us having a better understanding of this, I think will help us also approach our clients to be able to say, yeah, this happened now, but we're not quite sure what's going to happen over the next 2 or 3 weeks. It could be, in some cases, a great opportunity to find new behaviors. If there's any kind of inappropriate behaviors or difficult, challenging behaviors within that patient, maybe that's a great opportunity to work with a trainer or behaviorist in that situation. Or are there negative consequences of this that we're seeing within those follow-up periods as well? We don't really know. And so I think this is a good starting point for us to at least have the discussion. And then I'll post more on not this Monday, the following Monday before the next group, and we'll go a little bit more into what this actually means. What is this critical period, and start to discuss how is that going to potentially show up for us as animal health professionals. Good. That's all I have for today. And feel free to reach out if there's any questions that you want to bring up outside of this or any concerns. Please let me know. I'm always happy to chat about that.